Okay, sir. Good evening to all. Today topics of my presentation is the management of thrombocytopenia and bleeding, including recognition of disseminated intravascular coagulation. Before to start up my presentation, I would like to share this quote by a Nobel Prize winner in the medicine, Professor Edward Donald Thomas. Nurses and nursing are my secret weapons, without whom I could have never achieved my goals. This is for my all nurses. And now come to the objectives. Definition of thrombocytopenia, causes of thrombocytopenia, clinical presentation, nursing management of thrombocytopenia and bleeding, etiology of DIC, diagnosis of DIC by scoring system, pathophysiology in DIC, management of DIC, nursing care in DIC patients. Now, what is the thrombocytopenia? Thrombocytopenia is a condition characterized by abnormally low level of platelet known as thrombocytes in the blood. A normal human platelet count ranges from the 150 to 450,000 platelets per microliter of blood. Platelets are normally made in the bone marrow from the progenitor cells known as the megakaryocytes. Normal platelet lifespan is 10 days. It is common complication after the hematopoietic stem cell transplantation. Now we should know the critical values of the platelet counts. That is the 150 to 50,000. No treatment is generally required. 50,000 to 20,000 need close observation for clinical significant bleed. And 20,000 to 10,000, it's a life-threatening and starting spontaneous bleed. It can occur in the case of fever and infections. And less than 10,000, it's the risk of spontaneous intracranial hemorrhage. And you can see these are the in the smear plates are visible in the normal, and in the thrombocytopenia you see in the smear that platelet counts are not visible. Causes of thrombocytopenia in post HSCT are decrease the production and increase peripheral destruction. We have divided into two conditions. Thrombocytopenia due to the decreased production, bone marrow aplasia caused by high-grade chemotherapy and our total body irradiation. Insufficient platelet production after BMT due to impaired thrombopoiesis. It is associated with the dose of CD34 cell. Relapse are the persistent of the disease bone marrow fibrosis, drug-induced inhibition of marrow, and poor graft. Thrombocytopenia due to increased peripheral destruction. It's infection. Infections are bacterial, gram-positive or gram-negative, bacterial infection, viral, herpes, and skin vesicles, lung in manifestation, neurological complications, and CMV with the interferes with the hematopoiesis and the disturb the platelets clonal process, and fungal infection. And VOD of liver, injury to the hepatocytes due to the drug like busulfan and cyclophosphamide, and the peak levels peak days of the VOD in the liver is on day plus 12 post BMT, and we make diagnosis on the Seattle criteria. If bilirubin is more than 2 milligram per deciliter, and hepatomegaly and right upper quadrant pain, ascites, and unexplained weight gain of 2%, more than 2%, and 5% in the children from the baseline. abnormal alkaline phosphatase and the gamma glucotransferase GTT, jaundice and platelet refractory. Platelet, I would like to mention a few platelet refractoriness causes, and that is the non-aminoglobulical and aminoglobulical. That is non-aminoglobulical, that are the 70% to 80% acute bleeding, in which acute bleeding occurs, platelet consumption, fever, infection, medication like amphotericin B, vancomycin, and the microangiopathy and DIC. Aminoglobulical are the 20 to 30%, where ABO mismatch transfusions, HLA, platelet specific antibodies, and autoimmune thrombocytopenia (ITP). Where transplant associated thrombotic microangiopathy, systemic disease characterized by the microangiopathic hematolytic anemia, thrombocytopenia, and organs failure. The term transplant associated thrombotic microangiopathy defined as the lesion of the thickening of arteriole and the capillary wall in the prominent endothelial damage, subendothelial accumulation of the proteins and the cell debris, and the obstruction of the vessels, lumina, and fibrin in the platelet-rich thromboid. Diagnostic criteria of transplant-associated thrombotic microangiopathy is elevated LDH, thrombocytopenia, schistocyte in the peripheral blood, or the histologic evidence of microangiopathy on the tissue specimen, absence of the coagulopathy, and negative Coombs test, elevated D dimers. And clinical presentation of transplant-associated thrombotic microangiopathy are fever, anemias, thrombocytopenia, hemolysis, raised LDH, acute renal dysfunction, and neurological abnormalities. And in the chronic graft versus host disease, it is also caused thrombocytopenia, immune mediated condition resulting from a complex interaction between donor and recipient adaptive immunity. And chronic versus disease, it is beyond 100 days, and manifest as the ocular, oral, and GI, pulmonary, and the cytopenia. You can see this the clinical presentation of thrombocytopenia in number 1. The petechiae are present, and purpura, and ocular and congenital bleed, and in the mucous membrane you can see the, like this, it causes the bleeding. And I would like to share this few of ECOG toxicity criteria, where the thrombocytopenia grading are 0, 1, 2, 3, and 4, and it is in our BMT manual, nursing manual. You can see that in the thrombocytopenia, if it's within normal limit, we will grade it 0, and it's if the 75 to 75,000, it's a normal, and 50,000 to 74,900, it will be in grade 2, and 25,000 to 49,900, it will be in 3, and if the less than 25, it will be in grade 4. And hemorrhage, in clinical, you can see in the 0, it's a none, and in the grade 1, mild, no transfusion. Grade 2, gross, if 1 to 2 units transfusion may be needed. And the number 3, gross 3 to 4 units transfusion episodes are maybe needed, and massive more than 4 units of the transfusion are needed in the platelet transfusion are the needed. And you can see that, and in this if the within normal limits are 0 scale, and less than 1.5 it's normal, and 1.5 to 3 that is in grade 2, and 3.126 it include in the grade 3, and 4 it's a nephrotic syndrome. And hematuria, if less than 1.5, it will be in the scale 0, and 1.5 to 2.5 it will be in the normal, and 2.5 to 6 it will be in grade 2, and in the grade 3, 5 to 10, and if more than 10 it will be in the grade 4. This is the ECG toxicity criteria. Now comes to the nursing management of bleeding with the thrombocytopenia. Nurses should be able to detect sign of bleed, petechiae, bruise, hematuria, tongue bleed. Before I have mentioned in that last slide, the nurses should be focused and able to detect these signs, early signs for bleeding. Bleeding from mucous membrane, blood in urine or stool need the immediate attention in terms of platelet transfusion and escalation to medical team. If bleeding is present, consider applying the pressure dressing and topical tranexamic acid application. But tranexamic acid IV we are not giving in the case of thrombocytopenia. Provide emotional support to the child and parents as well. In the nasal bleed, cotton pack soaked in vasoconstrictor, and the anesthetic will be placed in the anterior nasal cavity. Assess of sign and symptom of the hemodynamic instability, including change in the mental status, pallor, and the diaphoresis, hypotension, tachycardia, and tachypnea. For oral and nasal bleed, patient required closer monitoring and support in the condition. We are making this magic mouthwash by tranexamic acid, syrup mucane, injection lignocaine, and the benzoatomide hydrochloric acid. And we are using it for the gargles. Increase the frequency of the oral ice rinsing. Continuing mouth gargling, tranexamic acid may require platelet transfusions. And for Jeju bleed, inspect urine at each while or at least every 2 hours to detect the frank bleeding. SC can be painful, especially when the passing clots. Pain management should also be considered. If gross hematuria or cysta is present, notify the physician, and platelet transfusion may be required for gross hematuria. For Jeju bleed, RCC transfusion is given based on the hemoglobin and the hematocrit laboratory results. Catheterization and bladder irrigation may be required, and avoid systemic tranexamic acid. And for the nursing management of GIT and CNS bleed, stool softener should be part of management of during the neutropenic phase to avoid the anal fissure. Hematemesis melina should be notified to the physician. Altered the conscious level, fits, photophobia, headache should alarm nurse for intracranial bleed during the neutropenic phase. Early detection and management can help limit the clinical significance of bleed. Blood component transfusion. Platelet transfusion is the mainstay of therapy. In an otherwise stable patient who no major risk factor, threshold for the prophylactic platelet transfusion of 5,000 may be acceptable if the patient is normal. If fever is present, this can be raised to 10,000. If other major risk factors are present, like coagulation, abnormalities, critical anatomical sites at the risk of bleeding, low albumin, hypertension, or sepsis, and 20,000 or more might. And there is the evidence-based superiority of the single donor apheresis platelet concentrate over the pooled random whole blood derived PC. In general, platelets express a very low level of the ABO. Antigen and ABO matching is generally not required, with the possible exception of platelet transfusion for intracranial bleed. In case of platelet transfusion, switching to the ABO type, single donor platelets and slow platelet transfusion can be helpful. Packed red cells at the dose of 10 to 15 ml per kg. The cutoff hemoglobin values are the prescribing is generally 8 gram per deciliter. With severe thrombocytopenia, RCC transfusion improves the platelet function. FPP transfusion is the indicated in case of deranged coagulation profiles. Remember, nurses must be remembered prior to the administration of blood product. Blood product includes red blood cells, plasma, and platelets. Check blood product, blood group, collection date, expiry date, blood volume, and date and stem irradiation before the administration. Must closely monitor the patient's vital sign throughout the procedure. And nurses must closely monitor the patient for the sign and symptom of the possible complication. The first thing always nurses must do is when a reaction or complication is possible, it is that discontinue the administration of blood or blood products and maintain IV light and inform the on-floor doctor. Okay. Before come to the thrombocyte DIC, I would like to mention this, that in general cases of DIC infection and tissue damage is the main cause in the post BMT patient. And no disseminated intravascular coagulation. An acquired hemorrhagic disorder, wide separate coagulation is always the initial event. Consumption, coagulation, and are multiple causes. You can see the systemic activation of the coagulation. It leads the intravascular deposition of the fibrin, which lead to the thrombosis of small and mid-sized vessels, which leads to the organ failure and then may cause death. And systemic activation of coagulation, depletion of the platelets and coagulation factor, which cause bleeding and may lead to death. Condition associated with the DIC are infection, septicemia, bacterial, gram-positive and gram-negative, viral infection, CMV positive, varicella, herpes, and fungal infection, intravascular hemolysis, and acute liver diseases. And tissue injuries, trauma, extensive surgeries, tissue necrosis, head trauma, and obstetric, although it's a very general, but it's not related to in the post BMT or BMT, but it's a general causes of the DIC, obstetric, amniotic fluid, emboli, placenta, and etc. And condition associated with the DIC, it's a malignancy, cardiovascular, hypothermia, pulmonary, and severe acidosis and coagulate vascular diseases and anaphylaxis. This is the clinical manifestation of the DIC, where organs, if the skin is involved in ischemic purpura and the fluents, gangrenes, and the hemorrhagic petechiae and the oozing. If the CNS involved, delirium and the coma in fogs, and in the hemorrhagic, intracranial bleach, in the renal oliguria, and in the hemorrhagic hematuria. And the cardiovascular myocardial infarction, and in the pulmonary dyspnea and hypoxia, and the hemorrhagic of the lungs. GID ulcers, and the, if the ischemic infarct and the massive. Endocrine adrenaline infarcts and the hemorrhagic. Bleeding, the most obvious clinical findings. And this is the clinical manifestation of the DIC, like a gangrene and purpuras. And the microscopic findings in the DIC are the fragments, schistocyte, and the passage of the platelet. By scoring system, we diagnose DIC. Platelet count more than 100,000, it is in the 0 score, and less than 100,000, it is in the 1, and if the less than 50,000, it is in the scoring 2, and the D dimer less than 1 micro, it is in the 0, and 1 to 5, it is in the 2, and more than 5, it is in 3. And PTT, if the less than 3 seconds prolonged, it will be in the 0, and more than 3 seconds, it will be in scoring 2, and more than 6 seconds, it will be in the scoring 2. And fibrinogen, more than 100, it will be in the 0, and if less than 100, it will be in scoring. Score will be more or less, it is indicative of over DIC with increasing score relating with a higher mortality. Now, laboratory diagnostic or thrombocytopenia platelet count is less than 10,000, rapidly decline, prolonged clotting timers, PTA-PT, presence of fibrins, degradation of products, or the positive D dimer, low level of the coagulation, and low level of the coagulation factor. Fibrinogen levels not useful diagnostically. Now, stop the triggering process. The only proven treatment, supportive therapy like FFPs, cryoprecipitate, fibrinogen, and platelet substitution therapy is given, and anticoagulants. No specific treatment is for DIC, but the triggering factor must be stopped. These are the few references where I have taken my presentation. If any question.